Alrighty guys, well why don't we get rolling here. Welcome everybody. I am really excited for everyone to be here with us today. My name is Dr. Dennis Hannon. I am one of the licensed psychologists here at MHS. I am very stoked for everyone to be here. I think this is going to be a great discussion that we have today here. A very important one too. Oftentimes we will go through treating our clients and our patients who are in the cancer treatment process, and unfortunately we tend to overlook as a healthcare system many different aspects of their wellness, and so I'm hoping we can kind of start to integrate those different aspects today and talk about how we can support the whole person rather than just maybe the physical or the mental separately. So we will jump into that today. Before we do though, what I would love for us to be able to do is just kind of share a little bit about where we're coming from. I would love to hear kind of like what your backgrounds are, what disciplines we're coming from. I think we probably have a lot of different perspectives in the room, and love to hear a little bit about that. So I can kind of start us off. Like I said, my name is Dennis. Feel free to call me Dennis. I do not love the doctor thing. I'd much rather be on a collegial level with everybody. As one of the psychologists here at MHS, I run a couple of different programs. I have a group therapy program for, it's called our Thrive for Chronic Pain Group. So helping individuals with long-term pain issues really kind of create the life that they want to be present in and improve functioning, overall functioning. Also run and part of the Thrive for Cancer program, which we implemented last year. Really excited about that program. We can talk about that a little bit today. I'm happy to answer any questions about it as well. Very similar to our Thrive for Pain group, very much focused on helping individuals kind of improve functioning, improve happiness, quality of life, things like that while dealing with cancer. Also have a couple of different groups, run a bunch of different DBT groups for those of you who are therapists and who know what that is. Essentially, it's a group primarily for mental health issues, for those of you who are not familiar. But then I also do a lot of individual therapy and supervision of students here too. So. One thing that whenever I start with a presentation like this, I always like to say, I really do not enjoy talking at people for 3 hours, and you guys, I promise you, you will not enjoy that either. I am not that interesting, and I do not know everything. So what I'd really love for us to do today is to make this a little bit more conversational. I think I want to fully recognize I don't know everything about what's going on at the intersection of cancer and mental health, and I think everyone in this room has really unique perspectives and anecdotes. And so if you want to bring those anecdotes in, those discussion points, those experiences, please do. Please share those. I think everyone in the room here can really benefit from learning from each other here today. So anything you want to toss in, questions, anything, please jump in with it. So the other thing that I was asked to do by our organizer here today is just remind everybody to make sure you sign in for your CEUs and then sign out as well. And then I think Tane will have certificates for CEUs for everybody at the sign out. And then if everyone can fill out the survey, I think that is in the end of the packet as well before you leave here today. That is appreciated too. So excellent. Thanks guys. All right, so what we'll talk about today. We will jump off and just kind of start with integrated wellness. What does that look like, right? A lot of us are coming from different backgrounds. It sounds like we have both mental health and physical health here, which is fantastic. I want to talk about both of those sides today, and that will be kind of really the theme of our discussion here today. How do we treat both sides? How do we support the client and the patient as they're going through both sides of cancer care and mental health issues as well? Right? Everyone has a reaction in some way or another to the cancer diagnosis and treatment process. And so how do we support all of that in one? All right, so we'll start there. And then I want to move into talking about kind of what a normative mental health reaction looks like. Everyone, like I said, will have that reaction in some form or another, whether that's just fear, whether that moves on to a trauma experience, could come out as depression, anxiety, a whole plethora of different issues. In some form or another, someone is going to have changes in their lives, physically, emotionally, psychologically, spiritually even, because of this cancer diagnosis. All right, so we'll move into talking about what that looks like on a kind of a normal reaction level, but then also how to differentiate that from more of a pathological issue as well. When it becomes more severe to the point where we need to look at getting the client or the patient connected to other services, maybe more mental health specific services. All right. From there then, we will talk, is anyone familiar with Fennell's phases of chronic illness? No? Awesome, all right. We're going to have a lot of new learners here today. We're going to talk about what chronic illness looks like longitudinally. what it looks like over the course of the chronic illness and how that correlates with a person's mental health reactions. All right. From there, then we will jump into talking about how to, just at those warm points of contact, how do we support the client? You know, whether it's in a 30-second interaction to a 1-hour session, what can we do to help the client from there? All right. And then after that, we'll kind of move into talking about what are our reactions like? How do we help manage all of what's going on for us? What is coming up for us? What do we need to watch out for in terms of our own kind of reactions to working with this population, this clientele? So, all right, let's start with the longitudinal effects here. All right, I picked this picture purposefully because I think, as we can all relate to working with these clients and this population, the diagnosis and the treatment process for cancer affects the whole person. The whole house is really flipped upside down. It's very much like going through a storm, unfortunately. All right? And so as we move through talking about Fennell's phases of chronic illness, what I want to do here today is really focus on this metaphor of the house being flipped upside down through the storm. All right? And so as you guys can see in this picture, that storm, after the storm, the house is very much destroyed. Doesn't look like it's very livable in anymore. And yet the foundation is still there. And I think that's an important point that we need to think about and keep ourselves reminded of as we work with this population. The foundation for the person is still there. They're still able to be resilient. They're still able to be functional. And excuse me, there is something there. There's always hopefully hope there. And if not, then hopefully the client is willing to work with us to help build and reinstill that hope. All right. That being said, the whole general experience of cancer is extremely difficult too. All right. What are some things overall that you guys recognize that you've seen in your clients who are living with cancer? Just general experiences.
I guess loss of control.
Definitely. Very common theme, absolutely. And with that loss of control can kind of come that the loss of meaning, the loss of purpose, hopelessness, helplessness, despair. A lot of that comes up for sure. What else?
Anxiety.
Yes, yeah. That loss of control can bring that anxiety up as well, right? As human beings, we like predictability. We like safety. We like comfort. Unfortunately, we can't always get that when we are dealing with a cancer diagnosis and treatment process. Anything else?
A change in your self-image.
Definitely. The whole idea of trust in our body, of trust in our plan for our future, it's completely upended when we're dealing with cancer, unfortunately. Yeah. Pain, right? Pain is a huge piece of the cancer process, whether that's acute or chronic pain. People will live with pain for probably years after their diagnosis. Physical changes, whether it's a result of side effects of treatment or long-term changes such as amputations and things like that, unfortunately. Anything else? How about mentally and emotionally? Go ahead.
Well, and I'm thinking more of some friends that have both went through cancer, are going through cancer, and have not made it through cancer. Is just kind of that loss of so many of the things in your life that make it worth living. That if you love being with this group of women, but then you can't go to that group because you're too ill, or you practiced yoga and then you can't go to that because you're too sick. All the things that either kind of make you or help your anxiety, or just give your life some of that pleasant meaningfulness.
Absolutely.
Can be really kind of taken away from you, and there might be other things that step in, but maybe not.
Absolutely. And as we'll see today, as we talk about kind of those phases of chronic illness, those feelings of detachment, that disconnection, kind of that loss of intimacy with what gives us purpose generally, or those people, those relationships that help us feel a sense of safety and security. People get disconnected from that immensely during this whole process, unfortunately. And during those first couple of phases of Fennell's phases of the chronic illness and cancer process, those feelings can be really immense. And that's where we really need to watch out for the mental health concerns for our clients and patients, because oftentimes that despair, that disconnection will pop up there and exacerbate any mental health reactions that people experience. Absolutely. Anything else stands out in your minds?
Fear.
I'm sorry, I missed
Fear.
that. Fear, yeah, absolutely. The unknown.
They feel like a burden to their family.
Very, very common as well. How do I support myself and not put too much strain on my family or my friends or my support groups and things like that? I know they're going through a lot as well. I know they're going through kind of their own treatment or grieving process, if you will. How do I take care of me and not have to put too much strain or stress on them as well? It's difficult for sure.
I think sometimes they have false hope that they're going to recover.
Mm-hmm.
They have grade 4 stomach cancer, lymphoma.
Mm-hmm.
How do you paint the picture that probably, that's false hope?
Yeah, which is both a beautiful and a tragic thing about the human experience, right? That ability to hold on to that hope until the very last moment, and unfortunately can oftentimes get us into trouble as well if it leads us to denial and maybe not looking at other options that we have in order to make ourselves comfortable too. It's really difficult for sure. Okay. All right, let's talk about Fennell's phases then. There has been a lot of research that has come out over the last several years related to kind of what the experience of a chronic illness is like and how people adapt as they're living with a chronic illness. Overall, Fennell is very much kind of the main researcher in this area. She has quite a few prodigies who are coming out with new research that's really exciting in terms of what it looks like to experience a chronic illness over the lifetime. But she's really kind of done the bulk of the research so far. And so this process of experiencing a chronic illness, it's broken down into 4 phases. All right? And these can, I think it's important to keep in mind as we talk about this stuff, these can shift and people can jump from stage to stage throughout the entire treatment process depending on what they're going through and oftentimes depending on kind of what news they're receiving from their care team. All right? And so we start with phase 1, the crisis phase. All right? Crisis phase is, if we go back to that metaphor of the storm, crisis phase is when there is a storm after a storm after a storm after a storm. Oh, sweet. Time to update. Let's see if we just do this. Well, we'll leave it for now. Hopefully it doesn't restart.
Because otherwise it might.
Good call. There we go. All right. Sometimes these touchscreens get a little finicky, but so crisis phase is that phase where people are experiencing storms frequently and often. This is most often right after diagnosis. So this is definitely when people start to recognize in their bodies that something is wrong. Something is happening, something's shifting. They may feel like they're losing their former level of functioning. There's a lot of pain oftentimes that comes with the the crisis phase. And this is when they're going to their oncologist, to their pain specialist, and receiving a diagnosis. This doesn't have to just be at diagnosis either, though. This can pop up again anytime that someone enters a new phase of treatment, so chemo, radiation, a surgery, anything like that. And oftentimes it will pop up at those major benchmarks in treatment too, because it is a whole new experience for that person to have to go through chemo or radiation or surgery. All right? And so the main task in this phase is simply to survive. We just have to get through this crisis. We just have to figure out how to help ourselves move through all of what's going on right now. It's really difficult for ourselves. All right? Welcome, come on in. And so in phase 1, I think the normative reaction is one of extreme fear. And with that fear, extreme confusion as well. I was talking with, and it might have been you before, Deb, it might have been you as well, about kind of the strain that is put on a person in terms of having to try to tackle the healthcare system when they first start to see an oncologist or they go to their primary care doctor for an issue that's been going on for maybe a couple of weeks or a couple of months that they don't really know what's behind it anymore. Right? The whole idea of having to understand and navigate a healthcare system is terrifying, it's confusing, it's overwhelming. And overwhelmed is very much the key word with this phase. People are constantly in a state of overwhelmedness.
I would second that. I mean, I was a pretty strong nurse, and still I felt very vulnerable.
Mm-hmm.
But the other thing is, I remember is being overwhelmed by the number of decisions you have to make.
Absolutely.
Yes.
And I would always counsel people to take someone with them, because as a physician starts to talk, your mind, or at least your mind, can go down this road, and they're keeping talking, and you're missing.
Mm-hmm.
And so I would take my sister, and she would, after she's away, she'd say, well, you remember when they said blah, blah? And I'd say, no, I don't remember that. So,
Unfortunately, that is the truth, too. I mean, that's the reality that people experience. The number of decisions, and most people do not have an advocate who is able to successfully or effectively navigate the system too, to help with
Know the
answers.
lingo.
Yeah, yeah. This is where we as practitioners and clinicians can be really, really helpful. Meeting with the patient for 30 seconds after they're meeting with their oncologist or a nurse and just asking, did everything make sense there? Can I explain anything in a little bit more detail? Checking in with them, how are you doing after that talk you just had with your provider? Anything like that can be really helpful. Within phase 1, the crisis phase, there's a number of different reactions that we look at, and so we kind of break them down into a behavioral or physiological reaction. Now, oftentimes that will look like, side effects of treatment. That initial treatment, people experience a lot of different physiological reactions in that way. Behaviorally, we start to see a lot of avoidance and a lot of isolation coming up for people. They start to disconnect from their relationships. Affectively or psychologically, again, there's a lot of confusion, a lot of fear. Despair hasn't quite hit yet. It's starting to build in this phase, but the whole idea of despair hasn't quite hit yet because people have to recognize first that they have to recognize, acknowledge, and accept that they are dealing with this diagnosis. And in this phase, there isn't necessarily that acceptance yet. But prior to that, there is still that sense of helplessness and hopelessness that can come up. Really difficult. Spiritually, we start to see a loss of meaning as well, loss of purpose, more kind of questioning like, what's the point? Why should I if I have to deal with this? We start to get the inklings of that. They haven't quite built up into real existential crises or fears yet. Can you all think of a client or a patient maybe you worked with who has presented in phase 1 before? Yeah. Anyone care to kind of share maybe a little quick case study of what that was like? Admittedly, we don't tend to see these patients here at MHS too much because these are the clients who are just starting off in treatment.
So I have one.
Sure, Julie.
Right now, a male who it's been a year since diagnosis, but with every treatment change, he hits that crisis mode again, and avoidance is what he goes to, and he drops off the map for 4 or 5 months at a time, and then he'll come back and then be presented with more information about treatment plans, and then drop off the map again.
Yeah.
He doesn't really reach phase 2.
Okay.
I've yet to see him in phase 2.
Okay.
Really.
Yeah.
So that's just one that I've been working with right now, is trying to help him through that.
Yeah.
But it's hard when there's a lot of avoidance.
Definitely.
Yeah, it's really hard.
Absolutely, and I think you hit on a key point there, that keeping these people engaged and taking care of themselves, really difficult because the fear is just so intense in this phase.
Yeah, and I can only speak for myself, but at Pennepin, we encounter a lot of, low income, uninsured, underinsured. There's so many other psychosocial stressors going on other than their cancer. And so when you add the cancer and the treatment to the pot, it just gets really messy.
Absolutely,
And
yeah.
that fear that someone touched on earlier really amps up.
Definitely, yeah.
It's a challenge.
Yeah, and when we're working with clienteles where the psychosocial stressors are there to pretty extreme levels even prior to the diagnosis, the cancer diagnosis, it makes things that much more intense and that much more complex too. Yeah. Thanks for sharing.
I work at HCMC.
Great, yeah. We did clean you guys up, man. There's no one over there today.
But I really encourage people to bring someone with, like you were saying, but a lot of our clientele don't have that because their lifestyle has brought them to a point where they have shut everybody out.
Yes, yeah.
And so they feel like they're in it all alone. And there was a case study, I remember, a breast cancer patient who would come to some appointments and then she'd not show for other appointments. These were initial ones, like getting report, meeting with the surgeon, med-onc, rad-onc.
Yeah.
And she was so overwhelmed and so many people were calling her that she would just scream into her phone, I want to die, I don't care, I'm done with this. And she actually has completed all of her treatment. She's much more calm now.
Wow.
And she actually shows up to her appointments and is kind of grateful. Doesn't really say, thank you, oh my God, I'm so glad you pushed me, but it's kind of, you can see it.
Yeah.
But yeah, it was a big struggle to get her to come to her appointments.
Yeah.
And actually follow through with treatment.
And it's those clients who really struggle in the beginning like that, but then are able to kind of make that transformation. Those are the ones we remember and that stick with us, right? Those are the really meaningful cases that we like working with.
Yeah.
So I have a question. Did any of you use any advocacy groups like American Cancer Society to find advocates for people? Has that ever worked?
We tried everything with this, yeah. And finally, I don't know if it was me that kind of spearheaded, but I said, I think she needs to have one person calling her instead of 5 people calling her, because she's just feeling very bombarded and doesn't really know who to talk to. And then the next time she came into the clinic, I had never met her before, and so I purposely went in and I said, this is who I am. I'm the one that's been talking to you. Just want you to know that there's a face to that voice that's been on the phone with you. And so she had someone she could relate to, because I work triage clinic and infusion, so usually she can find me, and she'll call up and say, I'm in crisis. And then there was also our breast cancer specialist, who's an NP, and she just works with the surgeon. And so she kind of reined her in a little bit too, and just said, okay, this is what's going on. Because you can hear Jane talk throughout the whole clinic, so you can kind of hear her conversation, and she kind of brought her back down too. But I just wanted her to know that there was one person that she could contact. And we have a navigator, and we have our healthcare worker and our social worker, so I think everybody was involved in her case. But she needed that one contact.
And it's amazing what happens for the patient when there is that human touch, right? That human connection. That all of a sudden things start to be able to come back to a little bit of place of a normalcy and some groundedness, and then we move from a place of crisis and despair to more of problem solving. But it takes another individual to sit with us in that space and recognize that pain and that discomfort for us to be able to do that.
And she had a lot of mental health issues that had never been dealt with. She was dealing with a lot of psychosocial stuff that happened years ago.
Ah, okay. Sounds like a complex situation for sure. Yeah.
It's really,
Go ahead.
the American Cancer Society is the best advocacy group to tap
Yeah.
into. Do you think that people come, or y'all were kind of like nodding that you use advocacy groups? I just want to make sure I'm aware of them, if there's other ones other than ACS.
I use a lot. I also use Be the Match, but that's more for stem cell transplants.
Sure.
But they have like Peer Connects, and volunteer to patients who've already gone through it.
Right.
So, and then I know Lymphoma Leukemia Society also has a Peer Connect too.
All right. It's helpful, so look in the foundations for that diagnosis.
Yeah.
Fine.
Thank
Thank you. I'm sorry.
No.
This is really helpful.
Yeah.
Firefly Sisterhood's fantastic.
Sister Firefly, and they match someone who's gone through cancer with
Forgot about
a
that.
newly diagnosed
And
person.
they have a lot of outstate resources as well, which is really, it's kind of rare in some of the more rural areas of the state. They're a great organization as well. But yeah, no, this is a great point. I think it's important that we're aware of all of these different resources and organizations that can help support our patients too. So, very cool. So if coming back to that phase 1, if we are thinking about phase 1, the last thing I will mention on phase 1 is that if this is our metaphor of the house in the storm, this is the house, when people are in phase 1, their house is constantly being bombarded by tornadoes. It's tornado after tornado after tornado after tornado. They're not able to leave their house, they're not able to get out of that storm that's constantly hitting them. All right? So then we move into phase 2 here, stabilization. Phase 2 is very much the phase where people start to recognize, and I use that language purposefully, they start to recognize that they will not be able to return to their former levels of functioning. There is not an acceptance of it, there's not a massive or deep acknowledgement of it, it's just kind of starting to hint at it, they're starting to pick up those hints that they aren't going to be able to do the things they used to be able to do. All right? And so if we're using our metaphor of the storm here, this is the person who is running out of their house after the storm, after that initial tornado comes through, takes a quick look back at their house, sees that it's dismantled, but then attempts to run back into the house and use the washer just like it used to be, use the dishwasher just like it used to be, tries to access their bedroom on the second floor even though there's no stairs and things like that. As you can imagine, in this phase, there is an immense amount of frustration, immense amount of resentment against the disease, against themselves, and some of the habits that might have contributed to their cancer. There's an immense amount of frustration towards other people in their lives who may be treating them differently because of this new diagnosis and their experience in the treatment process. A lot of anger and irritability can come out in this phase. The whole task of this phase then is to really start to gain a place of stabilization. Spread those tornadoes out a little bit more. A lot of it is through education, becoming educated, understanding the language and the lingo of the treatment process. That will help to start to spread those tornadoes out a little bit further. But there's still tornadoes hitting every so often as well, as they start chemo, as they go in for that surgery, things like that, as they meet with that new provider. Very difficult process to be in, very difficult phase to be in. And so cognitively, this is where we really start to see the scanxiety and the hypervigilance set in as well. Everyone familiar with that term, scanxiety? I think a lot of us are. So it's that anxiety about what does my next scan say? What does my next checkup say? You know, when I have to go meet with my oncologist, what are they going to say? Is it going to be metastatic? You know, what stage of cancer am I in now? There's a great deal of rumination around that, great deal of racing and intrusive thoughts around what's coming next, as well as great deal of thoughts around why can't I do the things that I used to do. I used to go run 3 miles a day. Why can't I do that anymore? An immense amount of that frustration comes out here. With that rumination, those racing thoughts, comes a lot of distraction as well. You know, think about your clients who maybe look like they are disconnected from where they're at right now. They're very ungrounded, very uncentered. They're not able to follow what you're saying in a conversation, or they're not able to read a form, even a HIPAA consent form, anything like that. It's because they are very much tuned into what is going on, that cycle in their mind. Really difficult. Affectively, so we mentioned the frustration already, great deal of irritability. This is where hopelessness starts to set in pretty heavily as well. This is where we'll start to see some despair setting in too. Because they're starting to recognize, they're just starting that recognition that their house is being dismantled, there's immense amount of fear still, but then there's also that helplessness that will exacerbate in this phase of what do I do now? I have no idea what I'm going to do. I don't know if I can live here. I don't know what my life is going to look like anymore. I don't know who I am anymore. Behaviorally, this is where the isolation ramps up too. People won't come to appointments. They won't go out to coffee with friends anymore. They'll avoid Thanksgiving dinner. They will avoid calling or texting friends anymore. They'll pull away from partners too. There is an immense amount of disconnection and a loss of intimacy in this phase because of that irritability and that frustration that can pop up. All right? Even with partners, why don't you understand what I'm going through? Why can't you figure this out for me? It's an uncomfortable process and phase for people to be in. Welcome, come on in. Moving into phase 3 then, our resolution phase, this is where people really start to accept that their life will not be the same way as it was. And actually, I'm going to rephrase my language there. This is where people start to acknowledge on a deep level. So not necessarily accept, but really acknowledge. All right, so there's more of that deeper understanding that life is going to be different from here. And so in our metaphor of the house, these are the people who are walking outside of their house after the storms hit. They take a look back, and rather than running back inside and in denying that, they start to see, wow, my house is gone. It's not here anymore. And the same goes for clients and patients in this phase. My life isn't here anymore. My life is no longer what I used to think it was. And so if you can think about it, on one hand, there is no framework for their if they had a certain way of understanding what the world was like prior to their diagnosis and treatment process, that framework's gone. How they understood themselves, the world, other people, their future, it's completely dismantled. And there's nothing there to replace it yet. And so with that understanding that that framework is gone, people will start to explore and just really start to dip their toes into the water in terms of exploring new senses of meaning and purpose. There's not a huge kind of throwing themselves into these new areas of support and connection, but just starting to kind of figure out their way with this. Can you guys think of patients in this phase? What have you seen from some of your clients?
I've worked with a young woman who, she went through her initial phase of treatment and then had a reoccurrence. And so after the reoccurrence and having gone through treatment, what we found was that she seemed to want to be still sick. Because it was way more comfortable for her to be in the hospital and be surrounded by doctors and those people than it was to be with her peers.
Absolutely.
Because, at 14, she had dealt with a bunch of stuff that 14-year-olds don't typically deal with, and she couldn't talk to them anymore. But she could talk to the grown-ups.
Absolutely.
Who were way nicer to her.
Absolutely. And that's a pretty common experience for a lot of our patients, right? All of a sudden, our support group, they don't know how to support us anymore, and so they leave, or we become disconnected from them in ways, and now all we're left with is that support of our care team. And those are the people we feel like we have the deepest relationships with when we're in this process, unfortunately. Leaves a lot of loneliness, unfortunately, as well. How about for others? Anyone else kind of starting to see certain patients or clients dip their toes into those areas of meaning?
I just had a patient, I guess, yesterday, kind of in the resolution stage where it's kind of gone through all these, but I see a lot of our patients' strength. Is huge for them, and the fact that they said, I reached my peak 5 years ago, and I didn't realize I was reaching my peak. I thought I was on my, going to continue on, and now I have to kind of realize that my strength is going to be where it's at. I'm still working towards it, but it'll never be where it once was.
Absolutely, yeah. There's that recognition that you're touching on of life was like that, and it's no longer like that anymore. And now I have to start to find a new purpose or a new focus of my life too. It's really difficult for clients. These are often the clients who we will see that would make great candidates for some mental health care. Stage 2 and stage 3, or I'm sorry, phase 2 and phase 3, in particular, is where clients start to feel like they're stuck. Right? And so if phase 1 is very much crisis, just managing the crisis, getting out of this storm, phase 2 and 3 is where they start to say, I don't know what's next. And if you can imagine having that question kind of pop up in your life, what do I do from here? Every single day, every moment that you're awake, there's probably going to be a lot of hopelessness and despair going on. A lot of anxiety about what direction do I move in? How do I live my life with this thing that is also slowly killing me too? Right?
I think one of the things that's different with kids is that so often their treatment phases are so much longer than
Very true.
adults. You're talking about 2 and 3 years of treatment. So that's laid out for them. So they don't actually ask, oh my gosh, what do I do next? Until they're done.
Very true.
And then that all hits because their roadmap ends and then they don't know what to do. So I think it's probably a little bit different depending upon diagnosis and kind of length of treatment.
Absolutely. And pediatric oncology, I would be interested to see if what the phases look like.
Yeah, it's pretty different.
Yeah, I would have to imagine so. I mean, for so long you're told what to do, how to do it, especially for kids, and then all of a sudden after all that's over, and the whole world that you grew up knowing is you move on from that. That would be difficult. Very, very difficult. Yeah. All right. Phase 4 then, we're moving into integration. And so with phase 4, this is really the phase where ideally we'd love all our clients to be, all of our patients to be as well. This is the phase where, if we're using that metaphor again, the person has acknowledged that they live in Tornado Alley. They've built their house up now. They have those senses of purpose and meaning, senses of connection, intimacy, and they've also been able to kind of build the house in a way, structure the house in a way, I should say, that is protected against those tornadoes. So the tornadoes might still pop up, right? The meeting with the oncologist at the 5-year follow-up, still going to be there, and there may be some bad news that comes at that meeting, and still people are able to understand and live their life with cancer rather than have cancer kind of dictate their life instead. So they found a way to thrive, if you will, even in spite of that cancer. Cancer is still a part of them, it's still part of their experience and their story and their narrative, but it no longer controls the narrative. It's not driving the bus anymore. So we still will see scanxiety, we'll still see some hypervigilance in this phase. And those things probably will never go away. They may decrease and lessen over time, especially as they're given all clears at follow-ups and things like that. But by no means will that fear ever completely subside, unfortunately. There tends to be less hopelessness and despair in this phase, less depression as well, less anxiety and fear, because they have new connections. They have new sources of support. Former relationships are re-engaged in, feel more connection to a spouse or a partner, kids, family members, friends, things like that. New community supports as well. Questions about Fennel's phases at all?
I guess I'm just thinking about this in terms of these phases and how they may hold true or not hold true. If your integration phase is, I'm now at the end of my life,
Yeah.
that this cancer is going to take it.
Yeah.
And I think that I see both things, that some people do come to that sense of purpose and meaning at the end of their life and acceptance and all that, and others, they don't maybe get the chance to do this.
Mm-hmm. Absolutely.
Or they won't, or whatever,
Right.
however you want to put it.
Right, yeah. Have you noticed what some of those differences in those experiences are like for people, for those people who are able to, maybe they're in stage 4 and they're approaching the end of their life, but they've moved into integration versus the people who haven't?
Yeah.
What are some of those differences that you've noticed?
There's a lot more peace.
Yeah, absolutely. Serenity,
Yeah.
for sure.
Really focusing in on what their values are and what's important to them. Or they might, like, maybe it's spending time with grandkids.
Yeah.
And that's the laser focus, or.
Definitely. It's a real connection to what is important to them.
Yeah.
Absolutely. And really manifesting, what's important to them too, and behaviors.
I have a gentleman now that I'm working with who is so obsessed about if his wife will overspend his life insurance money that it's ruining his relationship with his wife. He can't sleep. He feels like crap, and he's just can't get over it.
Yeah.
Can't get past it. He's just so freaked out about that loss of control about after he dies, what will happen
Yeah.
to his family.
Yeah. Sounds very much like he tends to be more in stage 2 and 3. That loss of control, the stuckness that comes up in those phases, difficult moving past that concern about what comes with this, or what happens with this money after I'm gone. Difficult for sure. Yeah, stage 4, especially end of life issues, they will muddy all of these phases up, absolutely. But I don't think, as far as the research shows, people don't have to be in certain points in their treatment to be in any particular phase. Obviously, with phase 1, we tend to see that more closely related to immediately after diagnosis for several months, maybe even years, unfortunately. And stage 4 does tend to come more frequently with remission. That being said, someone can be in stage 4 cancer and still be in phase 4, as I would imagine a lot of us have seen before. Some people may be in phase 4 cancer and still be in crisis mode, though, too. So, very fluid through the phases.
I guess I was also thinking that your personality and there might be an element of you, let's just say you have a super, super vibrant, rock solid faith.
Yes.
Or personality that's very dynamic and positive. And it's not that you wouldn't go through these, but I wonder too if maybe there might be, instead of going like this through them, there might be a little bit more leveling.
Absolutely.
Moves through them quicker, or
Absolutely, yeah.
process them differently.
We'll talk about this a little bit more later on, but there are absolutely certain protective factors, as well as risk factors too, that will help us essentially mediate or exacerbate our sensitivity to some of these reactions too. Lack of support absolutely can be a risk factor for making our reactions that much worse and intensify them immensely, maybe to the point where we're experiencing mental health issues. Right? Similarly, having, like you mentioned, like a source of connection to a faith or spirituality, something like that, a sense of purpose and meaning, that can absolutely be a more of a protective factor that may help to mediate, our reactions too. Very cool. All right, let's chat about how these things interact then. Extremely, extremely common for individuals to experience mental health issues and cancer co-occurring. In fact, almost 50% of people will experience some type of mental health issue when they are diagnosed and going through the treatment planning process. Julie, I saw you nodding your head there. It sounds like this is resonating with you, is it?
Yeah.
Yeah. Very cool. Unfortunately, though, most people will not receive treatment, unbelievably. There's several studies out there right now that indicate that as many as 85% of people will experience some type of a mental health reaction that is worthy of a diagnosis. Unfortunately, many do not go diagnosed. Yes?
Can you clarify, meaning no previous history at all of any mental illness?
No diagnosable mental illness. So I think it's probably fair to say most of us will experience stress in our life. Most of us will probably at times feel kind of a lack of pleasure in usually pleasurable hobbies and activities, things like that. When we are stressed out, we may feel, just kind of a disconnection from things, or there will be times where our anxiety gets a little bit higher. We call those subsyndromal issues, mental health issues. But what is meant by this is that no one has met previous diagnoses. So they haven't met the full criteria for a mental health diagnosis yet. Fewer than 50% of those people, though, who could meet criteria for a mental health diagnosis will go undiagnosed and they will not receive care. That is outrageous, isn't it? Anyone else just totally put off by that? Yeah.
What does that do on total cost of care, mortality? Have those studies been done?
I'm sure they have.
We have a lot of that literature for diabetes.
Mm-hmm.
And if we make the leap that they're about the same, it's exorbitant.
Yeah.
That if you don't get the mental health care and you have diabetes, the healthcare costs go through the roof, they skyrocket because that's not well controlled.
Mm-hmm.
And so I would imagine it's probably similar.
Absolutely. In fact, there are several payers in the state of Minnesota who have identified cancer, diabetes, and chronic pain to be their three big issues right now. Triple aim, and it's because of those costs of care. They're just exorbitant. Yeah. And putting mental health issues on top of that. If you can understand someone with depression, a lack of motivation, there's fear there's the hopelessness and helplessness. They're probably going to be more disconnected from their care and more disconnected from their care team, not want to engage in treatment as much, which is obviously going to make the cancer worse. It may make it progress further, which then is going to require more intense treatment, more expensive treatment too. Absolutely. Yeah.
You're talking about all the patients we have at HCMC.
Definitely, yeah, absolutely. Yeah, and substance issues on top of that, and it makes it so much more complex. Those clients and those patients, they have a lot up against them, unfortunately, at those points.
And I would also make the argument that as a psychologist too, I have an outpatient practice and work on our inpatient units too, so I'm dealing with a lot of people who have really extreme mental health issues. When I get to go and work with my cancer patients, I say to them, hey, if you take these deep breaths, you might feel better. And they actually do it, and then they come back and they're like, that stuff works. Right? Because I think they don't have those histories.
Right.
So they're still very receptive to treatment, and oftentimes it does feel like it's a lot more successful.
Yeah.
Than with some of our more chronically mentally ill patients.
Absolutely. Well, and those, I think, Michaela, you make a great point there too, those little points of contact, that little tool that you can give them right there in a 30-second touch, it does wonders for a lot of people. And for those more complex cases too, they need a little bit more care and support as well. Really difficult. Yeah. So let's talk about what those protective factors and risk factors are when it comes to mental health and cancer. Generally, when we're talking about protective factors, individuals who have a strong support system going to be much less likely to develop a mental health diagnosis when they're going through the treatment plan, the cancer process. All right. Individuals who are given accurate information about their cancer diagnosis and the treatment process as well, much less likely to develop a mental health issue. Why do you think that is? Any hypotheses to that?
What do you mean by accurate inaccurate information about
Inaccurate information, or they're not hearing the information. They may pick up bits and pieces. You know, the shock in that meeting with your oncologist may be so intense that people tend to get lost in their emotions and get distracted, thinking about what's going to happen to me, what's going to happen to my family, that they miss pieces of information from their oncologist or their nurse. And so they may fill in those gaps with kind of information that they thought they might have heard. That's a pretty common process.
The internet, too, I would say there's a lot of bad resources. There's a lot of inaccuracy on the internet, if you start down that road.
Very, very true. WebMD always comes up with some interesting ideas there. Yeah.
For
Do
somebody
they
that's
start
had a bad
developing a trust for them?
I'm sorry, go ahead one more
Do
time.
they start developing a more trust for their health professionals?
Absolutely. Trust is a huge piece here. When they are gathering that information, that accurate information, that will build the trust in the relationship. And the more someone feels connected to their care team, the more likely they are to have reductions in likelihoods of developing mental health issues, for sure. I heard another idea over here.
When people tell me that they've looked on the internet at their disease,
Mhm.
their second visit in, I'm like, don't look at the internet.
Yeah.
Because the people that have had bad experiences seem to be the ones that write the most on. the
Absolutely.
internet. If you've had a good experience, there are a few of them, but the bad ones are the big ones that pop up.
Definitely. We have as human beings, we have a negativity bias. To focus on what's wrong, it allows us to plan for that and survive and keep ourselves safe. But unfortunately, on the internet, that does not always do us good.
And that just promotes their fear.
Yeah.
More and more, and then they doubt
Yeah.
everything the doctor says.
Absolutely. Absolutely.
Well, and you hear your diagnosis that when you have anxiety and you're getting the results and the doctor told you it's stage 4 cancer, people's minds go to 15, 20 years ago, that was a death sentence.
Yep.
And now it's not,
Right.
but that's all they can hear, so they don't hear what can be done about it.
Absolutely.
Or my aunt had stage 4 cancer 10 years ago, and she died of heart attack.
Yeah. Absolutely.
Yeah, also with the antiemetics that we have now and all of the things, a lot of people think, oh, I'm supposed to be sick, I'm supposed to throw up,
Mhm.
I'm going to go home and just curl up and wait till
Mhm.
this passes.
Don't need to do that anymore. Yeah.
Call.
Yeah. Yeah, we can support you with that. And unfortunately, a lot of people won't access that resource, or they won't think about that, because that's kind of the template that we have in our head of how cancer treatment is. Whoops, jumping ahead here. That accurate information piece is huge, though, because that education that person gets into the language of cancer treatment and into the information that goes along with it, what the process is like, that education is awareness. And the more aware somebody is of the process, the better off they're going to be. They know what to expect, they can plan for that, and they can support themselves, and their family can support themselves more effectively if they have that education. It's a huge protective factor, Community supports is massive as well. We mentioned faith earlier. Having any type of connection to something that gives you a source of meaning is going to be massive. What other community organizations have you found that have been particularly helpful for your clients and patients who are going through the process of treatment?
I went to a Pathways. Pathways was very useful. And when I felt it was interesting because it wasn't specifically for cancer, it was chronic disease. So there are a lot of people, the whole spectrum from very severe depression to cancers to lung diseases, but people dealing with chronic diseases.
Yeah, absolutely. Pathways is an excellent organization. They have a lot of resources there. Pathways, a healing place, I think is the name of it. It's right on Hennepin in South Minneapolis. So, not familiar with it, check it out. Look it up online. They have a ton of classes and different types of healings available there that can be really helpful for clients. Even just to bring about a sense of relaxation at points where, there's a lot of anxiety and fear going on, and they feel like they can't relax. So, yeah. Any other particularly helpful organizations? Julie?
It's not cancer specific, but Face It Foundation.
Face It?
Yeah, so it's for men living with depression.
Oh, cool.
And so for me, it's been helpful for my male patients that come in, just because it's harder for them to connect with me, and I don't feel like I'm serving them as well as maybe a male provider could.
Sure.
And so I've had men come back with really good outcomes from those support groups, and And like we said earlier, it's hard to find someone who hasn't been affected by cancer.
Mm-hmm.
So oftentimes they find someone who has also been going through prostate or something of that sort.
Definitely, yeah.
Yeah, so that one, they're New Brighton, I think.
Okay.
Area.
I have not heard of them before, but
Yeah,
I'm going
they're
to keep that in
small-
mind.
Small organization.
Okay.
Yeah.
Very
The
cool.
man who founded it was a clinical social worker
Yeah.
who almost committed suicide
Yeah.
himself
Ah,
and then decided he wanted to do something.
yeah.
So, yeah, it's really neat.
Yeah, yeah.
organization.
Great way to break the stigma, too.
Yeah.
Very
Pardon?
cool. Great way to break the stigma,
Right.
yeah.
And he openly talks about
Hmm.
his struggles.
Interesting. Very cool. Sounds like a great organization, yeah. Any others? You know, Gilda's Club is one who, it's an organization that our clients here at MHS who are living with cancer, they find a lot of support there. It's a clubhouse, a psychosocial, essentially clubhouse support system. So they have support groups going on there. They have, I was talking with somebody earlier, they just have random classes like cooking classes and yoga classes. They also have more intensive kind of forms of support as well. They're a great resource. Gorgeous space too. Highly recommend. If you haven't checked it out yet, pop in there at some point. Allie is the director there. She'll be happy to give you a tour. It's an unbelievable resource for our community. Yeah.
Angel Foundation.
Angel's great too. Yeah, we love Angel here. Angel Foundation being the financial support system for, I believe it's all types of cancer, if I'm not mistaken. Anyone?
They do
Yeah.
a lot of
But they do other
family
things,
education
families
centers.
and for kids.
Yep. They have a lot of resources for kiddos and teens too, which are often overlooked. So, okay. So let's talk depression. Everyone's favorite topic. All right. Unbelievably, somewhat believably, having worked in this field, a quarter of all cancer patients at some point will meet the criteria for the diagnosis of depression. So 1/4 of people that you run into. More than half of all people will experience depression symptoms that may not be worthy of a diagnosis, but may be intense enough to be noticed. All right, so more than half of people. Sounds like we've already identified a bunch of those symptoms that could pop up here. Things like hopelessness, helplessness, suicidal thinking, in fact, will pop up more frequently probably than we would like in this population. Things like a lack of energy, fatigue, which are oftentimes difficult to parse out from treatment side effects as well. Really, really difficult to figure out what's what there. In fact, I'll throw out that question, like, how do you figure out, like, what is the difference between the side effect of chemo and radiation and medications versus what's depression? Any ideas?
What are they telling themselves?
It's a great point, Michaela. Yeah. What's the language or the narrative that they're using with themselves? This is because I'm depressed, or this is because I have no worth or value anymore. This is because of my side effect. Yeah. Any other thoughts?
Well, I had the thought of like using sleep as a tool of avoidance rather than sleep as a, I'm hurting, or this was exhausting from treatment, that kind of thing.
Absolutely. Yeah. I think it's oftentimes helpful to look at the time length or time frame of side effects as well. Generally, most medications and treatment modalities will bring a certain time frame where we would expect side effects to see. If that fatigue, if that lack of motivation, that kind of lack of affective regulation, if that is existing beyond kind of the time frame that we would expect for a side effect, then maybe we're looking more at depression as well.
We rely on the nurses a lot in our MDs.
Yeah?
Yeah, just to help me in terms of understanding medication side effects and
Mhm.
once they're like through active chemo, what other pre-meds are they getting? And are they just more understanding so that I can go into it when I need information. I go, okay, well, they're,
What's what?
A, B, C, and D, and they're probably a little tired. And,
Definitely.
Yeah.
Absolutely. Yeah. Yeah.
Using those resources.
At some point, do you ever go with the strategy of this issue is there and it maybe doesn't matter which one it's coming from? Like as a way to kind of neutrally address depression, because it's so much easier to say, well, it's a side effect and
Mhm.
depression has a different kind of stigma.
Absolutely. And at those moments, it's oftentimes helpful to have the whole care team there to really kind of discuss the options rather than just focusing on it being a mental health issue or being a radiation issue. Maybe, looking at all of the different possibilities in terms of where this could be coming from, and less so where it could be coming from, but where do we go from here now? That can be extremely helpful too. That integrated, coordinated care is vital for this population because oftentimes we do see those complex issues where things overlap. Okay, we are going to skip the video for now, but we'll swing back around to it a little bit later if we have some time. It's a short, I think it's about 6 or 7 minutes of a video just kind of a man who was treated at the University of Michigan, what his experience of living with cancer and depression was like. So I'd love to be able for us to get to it, but I also want to be mindful of time too and recognize we have a lot to cover here. So talk about suicide here as we're kind of moving off of depression. There is a very, very strong correlation between cancer and suicide, unfortunately. The rates of suicide amongst the cancer population, and this is just general cancer population, so not typical to any particular type of cancer or anything like that, it's more than double the general population. So I think it's about 24 cancer patients in every 100,000 people will complete suicide. So that's not even attempts, but that's a completion of suicide. I was not able to find any research or literature indicating attempts of suicide, but I would imagine that that number is probably much higher. There are certain risk factors, one of them being individuals who are at the later stages. So stage 4 in particular, there tends to be a much higher risk for suicide attempts. The first several months after diagnosis, there is a much higher risk for a suicide attempt then. But that number does not, or that risk does not drastically decrease across treatment. If you are thinking about Fennell's phases of treatment, think about the individuals who are in stage 2 and 3. If you're dealing with anxiety and fear constantly, you're dealing with a loss of understanding of where to go, what direction to take in life. These are probably the clients that we want to be careful and watch out for here. All right. Anxiety and panic. Very, very common in this population, unfortunately, as well. Almost half of all people will experience a diagnosis that is worthy of an anxiety disorder. All right, so that's more, you know, if we're thinking about depression, depression's about 1/4 of all people, anxiety is almost half of all people. 1 in 5 people on inpatient units will meet the diagnosis for panic disorder. So frequent panic attacks. As we've said, like the cancer treatment process brings a lot of a loss of control, a lot of ambiguity about the future, what to do, how to help themselves, what direction to move in, can be really difficult. And so it's understandable that people would feel an extreme amount of fear in these situations. When we are thinking about anxiety and panic, I want to delve a little bit more deeply, touch on this a little bit more, because these are probably the symptoms that we'll tend to see most. Anxiety is oftentimes picked up really quickly in particularly larger healthcare systems because anxiety tends to present a little bit more physiologically, especially panic, than things like depression might or trauma might. And so medical providers tend to be a little bit more attuned to the physiological aspects of anxiety. But there's cognitive and there's affective symptoms of anxiety too that we need to be mindful of. Rumination and racing thoughts. So getting lost in that cycle of thinking of what's going to happen next, where do I go from here, what's going to happen to my family, right? Kind of replaying that narrative over and over and over again. Really natural for people to get stuck in that, right? If rumination serves the purpose of problem solving, we're trying to figure out and plan for a future that we have no idea how to predict. So it's natural that we would go to that place. Our brain wants us to problem solve. It wants us to have that predictability and comfort and safety for the future. And unfortunately, it doesn't. There's not always a. We don't always have that ability to predict the future either. So have to keep that in mind. A lot of dread, a lot of worry, a lot of nervousness, a lot of confusion that goes along with this as well. Fortunately. Okay, trauma. In terms of prevalence rates with trauma. Please do.
So in the inpatient setting, we don't always get a lot of time with our patients.
Yeah.
Sometimes you might get called in for a care conference, and that's one of the only contacts we have with them. And so
Absolutely.
I'm thinking to myself, in terms of better assessing for depression and anxiety within this population.
Yes.
In the inpatient setting, where we might get 3 days in a row of seeing a patient, it's shorter stays and everything. What might be the most effective ways to try to get a handle on if what their state of anxiety and maybe panic and depression are?
That's such a great question. I think starting from a place of, if we can approach it from this method of looking at it, let me go back a slide here, really kind of going down these bullet points in these different areas. So being able to piece together, okay, so this person has a racing heartbeat that they say that, you know, pops up every 20 minutes or so, and it's really, really intense, feels like their heart's about to explode out of their chest. They're dealing with really shallow and rapid breathing, okay? They're also saying that there's racing thoughts going on and that they can't get out of this cycle of thinking about what's going to happen to their family after they pass. But then they're also dealing with a lot of worry and confusion too. Maybe all of these things are tied together in this kind of anxiety umbrella. If they're experiencing, you know, racing heart, trembling, sweating, things like that, but without these other side effects, or these other symptoms, I should say, maybe it's some of the side effects of certain treatments. Or maybe if they're dealing with cognitive factors, but not some of these other factors, maybe then that it's more of a normative experience of anxiety, or more just kind of that general fear that people experience to their diagnosis and treatment. But it may not be severe enough to be diagnosed either. And so ultimately it comes back to kind of being able to support the client in the moment. How do we take care of you? How do we help you help yourself in this moment too? And we'll talk about that a little bit more here, but a lot of it, I would say, is kind of being able to tie those different pieces together across the different symptom spectrums, if you will. So, I don't know, anyone else have any other thoughts on that?
I would say that I work in mental health, so I kind of come from a different side of it, but we sometimes will get cancer patients and what we see feels very normal, considering, and everybody else has got their red flags up and
Totally.
really freaking out. Like for somebody you don't get to see very often, or maybe kind of an entry thing, I would be like, so just in your life in general, are you kind of a worrier? Are you one to like tackle new problems? You kind of get more a personality style.
Mhm.
And then with this diagnosis, did that change that? You know, because usually a worrier is kind of a neutral term, and
Yep.
people say, oh, I've always been a worrier, or I was like, I could never read out loud in class, or I mean, you know, something just very benign, and then they'll say, when this happened, it exacerbated like times 100, or I got over it and this is what helps. You know what I mean? Like they may already even know their own coping style and what helps them, and so then that leads into a lot of kind of where you go from that.
Absolutely. Yeah,
Or
changes.
they may even say like, I feel like I'm handling this, but it's my, you know, significant other that's freaking out, and then that throws everything. I mean, like, it's amazing, you know, just having the right kind of open-ended question
I
in
also
a very
think-
neutral environment, right? They just.
I also think, like, we're all good Minnesotans, right? So we're not gonna tell you that we're freaking out.
Right.
Yeah.
We're gonna say we're fine,
Right.
but my stomach's a little upset. Do you have anything for me,
Right.
right? And I think that's the stuff that we really have to pay attention to. If you're
Absolutely.
getting the physical, but they're denying all mental health stuff because, of course, we can't talk about that.
Yep.
Then really kind of talking about how that's can be, you know, this can all be connected. I also see it with, in the inpatient world, when I've got kids that like their IV alarm starts going off, you know, that there's air in the line or something, and it's like, we've got to get a nurse in here, like right now, and they're like totally freaking out about it. You're going, okay, like you've been here for 2 days. This is not the first time this has happened.
Right.
We're kind of we all know what this is. Most people are like, can you just hit the button until we can get somebody in here? And if there's a reaction that's really abnormal, then you can be like, oh, there's something else going on. I
Mhm.
mean, I think there's a lot of stuff that people don't talk about because
Mhm.
they think it's normal.
Yeah.
So we have to kind of have our investigative glasses on to figure some of this stuff out.
Absolutely. One thing, Michaela, as you're speaking, like, reminds me of, I think oftentimes giving the client the education of what anxiety can look like or what depression can look like too, and putting the ball back in their court, not necessarily saying, hey, I think you have this, or I think you're dealing or struggling with this, but just giving them the information and letting them kind of chew on it for a little while. A lot of times clients will come back and say, hey, this reminds me a lot of what you were telling me about, can we talk more about that? And letting them just kind of process and develop their own thoughts around it can be, sometimes people need a little bit of space to think about things before they're willing to acknowledge that it might be there too. Yeah. Unfortunately, in inpatient, we might not always have that opportunity either. Yeah.
Right.
Makes it difficult for sure. Okay, trauma. Prevalence rates for trauma, again, particularly high amongst this population. 20% of people at some point, within the first 6 months of their diagnosis will experience trauma symptoms that are intense enough to be diagnosed with PTSD. So intrusive thoughts, avoidance of triggers like things like meeting with their oncologists or nurses, attending treatment, things like that. Other intrusive experiences such as nightmares or flashbacks, maybe to that initial appointment where they received their diagnosis. They will also experience hypervigilance, which is extremely common in this population. Really kind of focusing on and being alert to everything that could indicate that their cancer is getting worse or coming back. So that knee pain they might be experiencing, they might interpret that in a way that says, oh, my cancer is back. I need to figure this out. I need to take care of this, right? Or they could go the opposite direction too. My cancer is back, but I'm not going to go to the doctor. I can't deal with that again. Right? So 20% of people within the first 6 months will experience some type of reaction that's strong enough to be diagnosed with PTSD. At a 5-year follow-up, research shows that about 6% of people, whether they're in treatment or not, will still experience symptoms strong enough to be diagnosed with PTSD. So 6% of people, whether that's in remission or they're still in treatment. Pretty intense. Right. So most people, like I said earlier, are going to experience some form of a reaction. They're going to struggle with adaptation and adjustment in some degree. But a lot of people will experience a strong enough reaction to be diagnosed with PTSD too. Something to be on the lookout for. Okay, we will probably touch on normative versus pathological and then maybe take a little break. And so I think this is probably hinting at what your question was in the back about inpatient, kind of like how do we determine what's what. And I want to jump into our discussion here with just kind of pointing out what might be normative reactions versus pathological ones. So as we've been saying, intrusive thoughts, scanxiety, hypervigilance, kind of a disconnection from relationships, disconnection from community organizations, disconnection from work. Those are all really normative reactions. Most people will experience those as they're going through the treatment process, unfortunately. Unfortunately, though, a lot of our clients and patients will see exacerbated reactions, though, where it becomes things like depression, anxiety, substance use. They resort or retreat to more avoidance techniques, gambling, risky sexual behaviors, online compulsive spending, shopping, things like that, in order to kind of move away from and ignore, deny, or avoid anything that has to do with their treatment or their diagnosis, because it's uncomfortable, it's scary, right? Most of us as human beings don't like fear. We don't like sadness. We don't like the idea of not knowing what's next. We don't like confusion, and so we want to avoid all of that. Right? So these are just some general things to look out for when we are talking about a normative versus pathological reaction. Anyone willing to kind of share maybe about a patient you've worked with who kind of typifies, manifests as a typical normative reaction? Like, what do you typically see in the patients that you work with that would say, you know, this is not something that necessarily needs mental health care?
You know, worry if they have little children.
Yeah.
That doesn't mean you're depressed. You know, that's a normal worry.
Absolutely.
What's going to happen to my children if I pass away?
Yeah, what's going to happen to my family and my friends? How are they going to cope with all of this? Definitely feeling like a burden too at some point. Mm-hmm. Most people will experience that throughout the process.
Sadness that they just retired a month ago, and now they have this new diagnosis.
Yeah. Life transitions, and then dealing with kind of, my life is going to look a lot different already, and now I have to toss this on top of it. A lot of sadness and grief around that, for sure. For sure. Yeah, loss of, or sadness because of the loss of this life I could have had, or that I planned for. Yeah.
But then I have the money set aside for this.
Yeah.
Changing your financial situation.
Yeah. Brings a lot of fear, that's for sure. A lot more stress, too.
How about body image? Like
Yeah.
They have to have a colostomy bag, a tray,
Mm-hmm.
feeding tube. I I mean, I think that's move into pathological because it is a complete change in their body image.
I think this is not something we've touched on yet, but I think there can be a lot of shame and embarrassment that comes with some of those physical changes too. You know, needing to carry a colostomy bag, having an amputation, things like that. The shame that comes from my body failed me, that narrative of my body no longer works, I can't trust my body, that brings pretty intense reactions as well.
I remember a woman in one of my support groups who told me that she got up extra early every morning to make sure her husband never saw her without makeup. She'd had a mastectomy, without makeup or without her prosthesis and, you know, her wig. And I thought, oh my gosh, that's a lot of work.
Mm-hmm.
To have to worry about all of that and then also that.
Mm-hmm. Mm-hmm. I have a client who I worked with where she would still attempt to work out for about 45 minutes a day throughout the treatment process, you know, 5-6 times a week. And there's a great deal of frustration around when she got to that point in the treatment process where she realized she couldn't continue to do that anymore. And that frustration, normative for sure, but her focus and the intensity of her focus on working out, really, it had me pretty concerned to the point where we had to make a referral for some eating disorder assessments in order to identify if something was going on there. Yeah. Yeah. So a lot to keep in mind with this. So as we talk about figuring out what's normative versus pathological, I put a few questions up here that I think can be helpful for us in terms of trying to figure out what should we expect from clients, and then what do we want to be alert to. I think just starting with that general question of how are you doing? What's going on for you? Do you have anyone that you can talk to about this? You know, what's your support system like? Those questions, those open-ended questions, give you a lot of information. And sometimes it will help us figure out right away if the client does need extra support, if they need some mental health resources. And unfortunately, like Michaela, like you were saying, we are also Minnesotans, and so we are really good at kind of covering that stuff up sometimes. We don't like to talk about that, right? So delving into those areas a little bit more. And sometimes it can feel a little bit like prying, right? Sometimes we have to give some gentle nudges to our clients and patients to really help figure out doing so in a way where they're also comfortable with it too. Okay?
Well, and I know, do you have anyone that you can talk to about this stuff? Lots of people will say, yeah, and then my follow-up question is, so who have you told?
Yeah.
And if they go, nobody,
Yep.
I go, oh, so, homework.
Yep.
You know, like, because I think that is that piece where they may very well have people that they can turn to, but
Mhm.
if they're not going to, we might have to prompt them to do that.
Absolutely. That's where those gentle nudges pop in then, right? My favorite question to follow up with after that one is, outside of your care team, you know, have you told anyone or shared this with anyone that's not on your care team yet? Because a lot of people will talk to their oncologists, talk to their nurses, talk to their case managers and advocates about this, but they don't necessarily tell their sister or their brother about it either. Their kids, their aunts and uncles, things like that.
I just was looking at a chart yesterday where someone asked me about a patient that we hadn't seen for quite a while, and he passed away.
Oh.
And I was reading in the chart, and he hadn't told any of his family until he was in hospice.
Wow. Wow.
And they were all from out of state, so, and they said, oh, I wish I would have known.
Mm-hmm.
And that is just so sad.
Mm-hmm. Absolutely. Your story reminds me, this is a bit more personal, but in high school I had an anatomy teacher who we found out later had metastatic lung cancer, stage 4. And between the period of diagnosis to her end of life, it was about 3 months. And she didn't tell a soul except for her best friend who was a math teacher there. So we all were pretty shocked by it. And not that it was any of our business as students, but she hadn't told her husband, she hadn't told her kids. She didn't want to be treated any differently. Yeah, yeah.
I also had another patient at a different facility that I worked at. She didn't speak any English, the patient, and the family would always come in and say, do not tell her, don't say the word cancer.
Oh, wow.
We do not want her to know this.
Interesting.
And I was very conflicted, saying, I'm an advocate for the patient.
Yeah.
I feel she needs to know.
Yeah.
They were adamant, and they wouldn't let an interpreter come in.
Hmm.
So
That raises some interesting ethical dilemmas there. Yeah. Well, those questions can be a helpful place to start to kind of identify where we can address issues with clients in terms of normative versus pathological reactions. I always appreciate kind of taking what I like to call the FEED approach, though, too. So we're looking at the frequency of symptoms. How often is that worry there? Is it there all the time, every single day? And the duration as well. How long has it been there, too? Has it been there for just a couple of days, or has that sadness been there for about a month or longer? Have you felt completely numb from everything for the last couple of months, or is this just a new development? Okay. Looking at the intensity then too. You know, I really appreciate having clients and patients kind of rank things on a 1 to 10 scale. So you know, you came in here last week and you said that numbness was at a 9 out of 10, and it had been that way for a couple of weeks. Where is it at now? It allows us to kind of give some measurability to where they're at in their symptoms. So those can be really helpful. I think one of the most helpful things to keep in mind when it comes to normative versus pathological reactions, though, is the impairment in functioning. Is your numbness leading you to a place where you're completely disconnecting from all relationships, where you haven't left your house for a week? Or is it just kind of a transient state that you feel like you're in right now that subsides when you feel like you're engaging in something that you usually really like, or that you had a nice meal with your partner over? Or is it there constantly? You know, is that fear? Is that anxiety? Is that hypervigilance? Is it getting in the way of you being able to read basic forms or even read an email because you can't concentrate so much? Or is it coming and going? Things like that. So,
But if their oncologist told them that they shouldn't go out because it's flu season,
then we need to have a care team meeting.
right?
Yeah.
Because we have that a lot.
Yes. Or it's too cold out and your pain might be exacerbated right now. Yeah, that's a common one I hear right now too. Always pull in the care team then, you know, for those broader issues. It can always be helpful to coordinate. Any other thoughts as to like how we can differentiate normative versus pathological reactions? Anything that you guys do maybe on the floor, on the unit, or in your outpatient practice?
I just have a question.
Yeah.
Do you know approximately what percentage of people do not tell hardly anybody about their diagnosis?
That is a fantastic question. You know what? I don't know the research behind that. Does anyone else? Oh. I wonder how they would measure that. Yeah.
I would
Would they tell the truth?
Yeah.
Well, and I think that there's probably been a pretty broad shift, because if we looked at data from 50 years ago, you know, that's still when you had to whisper the word cancer.
Yep.
You certainly didn't talk about what kind or where or anything like that.
Absolutely.
Versus now, where people are like, you know, showing up in their clothes that have the symbols, and it's much more open and accepted. So I think some of that data is probably inaccurate, because we'd have to look at the age of the patient and, you know, all of those other factors. Because there's still a whole group of people that won't talk about it.
Absolutely, yeah. Yeah.
Yeah.
Massive stigma. Older white men in particular really struggle with any type of treatment. Yeah. And vulnerability is not allowed. Have to be strong, right?